I'm going to talk about intravascular ultrasound in CCSVI. And as Kevin talked, many of these abnormalities are at the valve, and I think intravascular ultrasound is the best way to evaluate the valves. When I first met Paolo Zamboni, and I showed him a venogram that I had done, and I pointed to these abnormalities, he said, those are not significant. They're related to the fact that blood is flowing because of the obstruction into the vertebral vein, and therefore there was underfilling of the internal jugular vein, so that without its normal distension, things that are surrounding the vein will compress it and show abnormalities. They're not real. And I went back on the plane. I said, how the hell am I going to determine which of those abnormalities is due to underfilling and which are due to a fixed stenosis? I thought it would be really challenging. Well, as many of you know, when you purchase an interventional suite, it's the best time, sometimes it's the only time, in which you can get devices. So you load everything that you could possibly ever need into the big quote, because a $2 million a piece of equipment, well, another $100,000 is only 5%, but if you go to the administrator and say, I need a $100,000 unit, they don't have the money. So, and it's a different budget, et cetera. So when we built our suites in our new hospital, I got an intravascular ultrasound, and it sat in the closet for 5 years, never been used. But on the plane I said, well, maybe I could use that and use the ultrasound to see whether those narrowings are fixed or phasic. And thus, on the very first patient I ever treated, I started using intravascular ultrasound. And except for a very short period of time, when I transitioned from the university hospital to American Access Care, and we were deliberating on what type of IVUS to purchase, all my cases have been with IVUS. So I have almost 250 patients and experience with IVUS. And I must say, just as an editorial before I talk any further, that I can't imagine ever doing this procedure without intravascular ultrasound. I think it changes this game from, I think the stenosis is near the valve, to the stenosis is the valve. And there's nothing wrong in most cases with the wall of the vein. Nothing at all. The vein is pretty much a normal vein, and all of the problem is in the valve. Kevin showed an ultrasound that showed a valve leaflet sticking out in the middle of nowhere, but did you notice that the vein wall was not narrowed? The vein wall was normal. And very often when you see the cusps, those cusps are filling by retrograde flow on the outflow side of the valve and filling the entire vein between the wall of the vein and the downside of the wall of the valve. And sometimes you can actually see the valve opacified between the lumen above the stenosis and the cusp below. You can see it, it's very obvious. So I'd like to show you some experiences with intravascular ultrasound today and perhaps make a point. We have limitations to our existing equipment. We have difficulties in seeing the uppermost portions of the J3 segment. We have difficulty seeing the J1 segment below the clavicle on external ultrasound. My experience is that MR venography is extremely misleading, that many of the narrowings that I see on an MR venogram, I don't see when I do a venogram at all. And I don't understand what I'm looking at. Venography is interesting and useful, of course. It's our roadmap for intervention, but there's difficulties and some limitations. If the contrast is too dense, you may not even see a stenosis. If you do hand injections of the contrast, you can create a false sense of reflux or miss the reflux if you do it too gently. And you only see the contrast during a fleeting second as the contrast goes by. So every time you want to interrogate an area again, you have to inject more contrast media. So sometimes that can be quite a bit of contrast. And finally, every time you use it, you're using ionizing radiation. So while I think it's necessary in most cases to do venography, I think you can eliminate a lot of the venography by using something that doesn't have ionizing radiation in a real-time manner. So I'd like to discuss here the techniques for IVUS and illustrate a number of abnormalities that one can see on IVUS. And perhaps I won't do it on this talk for time, but in the second talk when I talk about using IVUS as a treatment guide, we may talk more about stenosis, analysis, etc. So this ultrasound is real-time. It's put in intraluminal. It's about a 2.8 to 3.3 French catheter. It goes over a 0.014 guide wire. And it tracks very nicely. It's a rapid exchange technique in which only the IVUS in the short end on the the most interior part of it actually has the guide wire. The rest of it has, the guide wire doesn't go through the whole catheter. It shows a very narrow field. We can't really get more than a 20 millimeter field of view in our patients. So if you have a 24 millimeter vein, or you can't get the vein to be centric on the ultrasound probe, you're not going to see the entire wall of the vein. So that's a limitation of the current devices. Blood is echolucent, and the wall itself is echogenic. So anything that's solid tissue inside that lumen will give an echo. And so there are many things that we can see. We can see the wall. We can't see very far beyond the wall, but inside the wall we can see septums. We can see the valves. We can see the motion of the valves. We can see webs, which is kind of an interesting thing. I really can't see webs on venography, but I can see them on IVUS. And we can measure a number of things. There are probes that will measure flow rates and pressure, and there are others that can characterize tissues. And there's different colors assigned to different tissue characteristics. Unfortunately, they're all for coronary artery disease, so we can get pretty pictures with colors, but we can't say this is a thickened valve, or this is type 1 collagen, or, you know what I mean? But there's an option if we can figure out how to get specimens for the company to analyze them and assign a color to various tissue characters. Here's a device. There are two primary companies in North America. I'm not going to mention either one of them. You can see on this particular catheter, the far right, this area right here is where the guide wire enters and comes out here. And the rest of the catheter just follows along adjacent to the guide wire. The difference between the two is that one has its guide exit port only about a centimeter from the tip, and it's really not enough of a wire inside the lumen of the probe in order to give you good control. There's no contrast injectability through these things. Some of them have markers that allow you can kind of see where you are, so you don't have to watch it going up into the body. When you get to this marker band here, it's about 75 centimeters, so you can put fluoro if you need fluoro on only when you get to it. It's very useful. I'm going to skip that. Okay, so let me just, I guess we've done it all. It's a real-time cross-sectional view with an intraluminal tissue assessment with no ionizing radiation. It's very safe. The only complications I've had with this device is before I used a very long sheath that I park in the superior vena cava, it's possible for the guide wire and the device to buckle into the heart and cause arrhythmia. And I had one patient develop atrial fibrillation that would not convert quickly. We had to admit the patient overnight for that atrial fibrillation. Other than that, occasionally it will buckle out of the vessel you want. You have to redo it, but generally it's pretty good and pretty safe. The disadvantages are that it costs about $120,000 for the unit. And the per case cost is expensive both for equipment and time. So the catheters cost about $600 to $700 each. And I would say it adds about 30% time to a procedure. A procedure I might be able to do in 45 minutes could take an hour, hour and a half, because I have to go, I use the IVUS after the venogram. I then use it after treatment. If I see something on there, I'll then do a second treatment, do another IVUS. So that's back and forth. It could be time consuming. And of course, those time costs are not just your own time, but it's all the personnel in the room. And it also decreases the number of cases you can do in a day, so it is pretty costly. At the current time, the insurance carriers and CMS sometimes do reimburse for it, but it certainly doesn't, that does not compensate for the cost, both the real and the time events. However, I think that it's just so valuable to me that, you know, I can't imagine not doing it. This is what the IVUS looks like. You advance the catheter. The IVUS catheter, well, you advance your diagnostic catheter as high as you want to go. You put in the 014 wire. You thread up the IVUS device to the top, and you turn on the unit. And there are echoes through the center. If you can look carefully, you'll see right in the center of the vessel, there's a little arrow, and that's where the catheter is. So you can rotate it and get a different view, and you just pull the catheter down. There's two ways. There are machines that will slowly pull it down for you, and you can do it manually. I do it manually all the time. If I see something abnormal, I will, you know, stay there for a while and try to understand what I'm looking at. And what we're looking at is the wall, echoes off the wall. In this situation, we're seeing some part of a valve, and this is a reformation of that, the image on the right is a reformation of that axial image to give us a longitudinal image there. And I'm starting to learn how to interpret those images, but it's not so simple. This is using another device. We'll give you flow rates and pressure measurements. I don't use that at all. I decided that the first year I would focus on one device at a time. So next year I'll start to explore how I best can use the other pieces of it. This is what's called chromaflow. Chromaflow is the association of a color with different tissue patterns. And this is an illustration from an article. I don't use it. This is in the dural sinus. Venography showed a stenosis of the dural sinus. And you can see that what it represents really is a considerable amount of thrombus and areas of the sinus that have flow. This is an illustration of that. So the red is all thrombus. And this is after stenting and giving a lumen back to that transverse sinus. So I don't use it too much at this point, but there may be some roles. So the goals of the purpose of the IVUS procedure is to analyze the wall of the vein, both for its diameter and look for intraluminal tissue that I've already described. The most common piece of tissue that we see is at the valve. And you can identify the valve. You can identify that, unlike the image that Kevin showed, there's irregular thickening of the valve. There's a bright echoes on the valve itself. And I'll show you what those valves look like. And we can see, so far I've been able to find what I believe are these pathological states with IVUS. I'm going to illustrate many of them, but I won't illustrate them all. Here's a case of a septum. The septum is hard to see on the axial images, but if you look at that cross-section of the the longitudinal image, you see this bright signal extending down in the middle of the vessel adjacent to the probe itself, and that represents a septum. I might say that I didn't see that septum on venography. You can see duplications, which are really a septum and a second lumen adjacent to that. This particular septum originates at the origin or at the confluence with the subclavian vein and extends upward towards the head. It's a blind, this one happens to be a blind ending sac. So while we see here a hypoplastic vein on the left, you can barely see it, you can really see the catheter only. On this other view, which is the first catheterization, the catheter goes into that lumen, and on the venogram it looks like there's a complete occlusion. The flow goes neither up nor down. The guide wire won't go any deeper or higher than that particular area. And it's a blind ending sac that on Valsalva maneuver compresses the true lumen. Here's another example. This was initially thought to be a thrombosis of the jugular vein. We couldn't get the wires past it. We couldn't get contrast to go through it. But eventually, we were able to get into the true lumen and get the guide wires you can see in the middle above that area. And then you see the IVUS on the side. The area of this is not working. Here we go. The area here is this. And the true lumen is here. And I played with this. With the IVUS in place, had the patient do Valsalva, and this distends. It's a blind ending sac. You put pressure on it, and it compromised the true lumen. I don't know how to treat that, but sometimes you'll see these small, irregular, hyperechoic areas. This is probably artifact. But this is clearly reproducible. You can bring the IVUS up and down, and when you get to the same location, you consistently find these areas here. And on the longitudinal view, you can see that that is real tissue seen again, and this represents some kind of intraluminal web. This I would treat, and it's pretty, easily treated. And on a follow-up IVUS, it's no longer visible. So we've torn open whatever those web-like strands of tissue are there. This is a very interesting case. There was narrowing here, and to put the probe in the same area as the narrowing. And what you see is that there's really no lumen. If you move the catheter up here, there is a lumen. And you can see that there's complete obstruction. Now, this is not a longitudinal stenosis because, we don't see that. This is the IVUS probe being held in the same location, and this is just axial image by time. So it's not a one-to-one relationship. If you leave the probe in one location, you'll only see that area. But I bring it to your attention is if you pull it up or down, go up here or down here, you see this, and in a very, very narrow point, transversely across, you see this. So this is a pure horizontal membrane, probably a malformed valve that is completely obstructive. Here you see this tissue around the valve. Around the probe. And that's what I'm pointing to this with these yellow arrows. In addition to that, there are these other signals that are out here. And on this image, what you notice is two things. You have multiple lines here. And if you, I think we'll show this later on, and perhaps not this case, but another one. This narrowing, this area here is the true lumen. This is the vein wall. So what is between this? This is the valve. The valve is eccentric. it funnels into a narrowing. If you pull the probe and go from top to bottom, this circular area of thickened valve gets progressively smaller. It goes smaller and smaller and smaller. So if you reconstruct it in your mind, what you're seeing is the valve, an elongated valve, forming a funnel. But the bottom line is that this is the vein. There's nothing wrong with that vein. It's the valve. The valve's the problem. And this one has webs as well, but that's I think that's really key for what we're doing. Now, this is an interesting situation. We have, the usual valvular stenosis here, but this is a sheath that I've advanced up here, and that sheath is nearly occlusive at this point. So the question arises of, is this a Palo-Zamboni perfused or low volume reflection of this stenosis resulting in collapse of the vein, or is this a hypoplasia? Well, these are two static images, and you'll have to believe me for the moment, but we'll show real-time images. This is during inspiration, and this is due to expiration. And you could see that this narrowing is not a fixed stenosis. It markedly distends. It's very much like those venograms we see when we turn the head and the vein looks small. They're compressions. We can deliberate about whether we need to treat compressions, but I think we need to differentiate a compression from a hypoplasia. And this is a very, very useful way to do it. This is another luminal narrowing, but this is intimal hyperplasia from a stent that was placed by somebody in this room a long time ago. Patient came back with an occluded stent, and it's all intimal hyperplasia. There was no thrombus in it at all. This lumen was created by my catheter as a pre-dilatation event. And here is some reflux. Well, not reflux. I have now decided to do all my catheterizations starting in the dural sinus because I want to assure myself that I've interrogated and have visualized the entire outflow of the jugular vein, because there are stenoses that occur in the petrous bone as well as above. And here you see these collaterals from the dural sinus, and on IVUS there's thrombus in that area. And as we get lower, we see that there's a stenosis in the vein. Okay, so these are the things we really have to try to figure out, because I think the ones that we really need to work on are these, and these we need to scratch our head and figure out over time whether we should touch them or not, because I've blown up balloons in them and I don't see any effect. So I don't think we really could do much for them except stent them, and I'm unwilling to stent very often. So the question is, which of these areas of narrowing are real? Well, we commonly see a narrowing here, and that's at the carotid bifurcation. So you can see the carotid here. I think, where is it? It's hard to see on here, but I think this is the carotid, and this is the jugular vein. And when you activate the thoracic pump and you increase the flow through the vein distends away from the carotid artery. So that clearly tells me that this is not a stenosis at all. And here's another example, the carotid. You can see the indentation on the vein. If you image the jugular vein in this projection, you would see a pretty small lumen, but it distends on its own. So, and here is a patient, I could have sworn this was going to be really abnormal. Catheter is beyond what looks like an obstruction. There's tremendous reflux on all three of these views. And this is the inspiration and expiration real time. So we can't rely on the venogram alone. I have never seen a candy wrapper stenosis in 250 cases. How could that be? I think it's because I do all my azygos venography in deep inspiration. And in deep inspiration, the vein distends in the azygos vein. So we have to be really careful of many of these things to see if they're real. I don't know if anybody would stent that, but that seems physiological to me. So I've left this question as as a question: is are these intermittent stenoses contributing to the clinical manifestations of CCSVI? And are transient stenoses structural defects in the wall that make it collapse? Or is this just a normal phenomenon as the vein torques and moves normally during the phases of respiration? Will stent reinforcement of those veins be of value? Well, I think that we have to do some randomization of those types of abnormalities to see whether patients are improved. Does their transience argue against treatment? I think that's a big important question because it's not uncommon. And I've seen many stents in those areas. Here's another case of a narrowing. And you can see these circular echoes. There we go. You see the valve? It's so eccentric. I wish I slow it down. Let me see. It's circular. This is an area of slow flow. But the rest of the vein is normal sized at that level right here. So what looks like, what I thought was a complete strictured jugular vein is nothing of the sort. So my strategies now are to focus on treating this, not this. So ordinarily we would all put in balloons that were bigger than the diameter of the vein. Now how do you do that in a situation where you have a stenosis? Do you dilate to this segment? I don't know. I don't think so. I think you can look at it in a better way. Now, you see this jet of contrast. That looks like the stenosis, but what is this contrast? This contrast is coming down and then backing up and filling this area of the vein. If you do this with very rapid sequence, you can see the dynamics of the flow dumping down and going back up on the downside of the valve. If you don't have the proper contrast density, those two densities can merge and you can think that you have a normal vein. I have made that error myself on venography. The IVUS has helped me out, and I have had many patients come to me for consultation because they had a normal venogram, and once you understand it, you'll find this kind of thing, and understand it, you'll detect the abnormality even without the IVUS. These are tubular, and they just this is a better one because we can see the whole vein, but the vein is very big, but this is the lumen and it's really small. Here is an incompletely opening valve. You see the lumen, but then you see this area here, and this area here gives a double echo. And what we're doing is we're echoing here, it's bouncing, reflecting off of the wall, and it's reflecting off the edge of the valve that doesn't open at all. Here's a patient who was treated at another institution. You can see the dilatation has profoundly affected the vein compared to the vein above it, but the stenosis was untreated. And this stenosis is not this long, it's much shorter, and this is the stenosis right here. So we can measure the stenosis by measuring the diameter of the lumen and the diameter of the stenosis, which are at the same exact level. There's not measurement of stenosis compared to this. It's a stenosis here compared to the vein that you don't see. It's a much more accurate assessment of that. Here's a case that is a nice illustration of the immobility of the valve. I'm going up and down through the area of the valve. It's somewhere in here. I don't remember where, but I can pinpoint exactly where that valve is. And sometimes that's useful. For example, if the valve is here, then there's nothing wrong with this. It's just underfilled. So I put my balloon from here down. I might not even touch this area. And I avoid stretching a normal vein. So I think it's useful in most planning. So I believe that IVUS shows clearly that the most common cause of stenoses at the confluence of the jugular veins is a valvular stenosis itself, not a stenosis of the vein near the valve. It is the valve. Being a wine aficionado, I made an illustration here using a couple of my wine decanters to illustrate what we're seeing. We're seeing the vein, a valve, and the rest of the vein. Now, what is the pathology of this? I can only give you conjecture because we don't have specimens. I believe that the valves are adhesed. The leaflets are adhesed together in most of the situations, and therefore they don't open and close. Is that congenital? I don't know. Is that inflammatory? I'm suspicious. But I think that IVUS is very helpful in making those assessments, and I think we need to use it a lot to really understand how to treat. Thank you.